So, good afternoon, all. Welcome to our sixth session. Today, we have Dr. AJU taking a session on pain and its impact for us. So, we can start with presentation of doctor. We will have his presentation for around 40 to 45 minutes, followed by a discussion for 50 minutes. We can start our case presentation by 4 o'clock. So, happy to see you all. Thank you for joining in.
Thank you. Can you hear me? Yeah, just give a thumbs up if you can hear me.
Over to facilitator now.
Okay. Can you hear me?
Yes, sir. Myself, Vaishnavi, working as a
Okay.
director
All
officer
right.
in Pallium. So I'll be facilitating the session. Thank you so much for joining with us. And for the participants' information, Dr. Aju is a medical oncologist by profession, based out of Kochi. That's what I came to know. And he's also an honorary consultant for Trivandrum Institute of Palliative Care Sciences. So welcome to you, sir. Thank you for accepting our invitation. So over to you for having a wonderful session.
Thank you. So today's talk is about pain and its impact. Now, I was thinking about what I should talk about and how my talk would be beneficial, and I thought I would talk more from my personal experience of taking care of patients with various kinds of pain in my own practice. And a lot of what I'm talking about comes from my personal experience, and also some of the cases that I will discuss to give you to illustrate how this is important are things that I encountered in the last a week or so. So, pain and its impact, it's an easy answer for everybody. If you ask anybody, any child, anybody in the road, is pain, how does pain impact a person? The answer would be, next slide, it's bad. It is bad, and that there is no two-way about it. Pain and its impact. My entire talk can be summarized in one word, and it's bad. Now, next slide. How does it impact a person? It impacts a person's physical well-being. It impacts a person's emotional well-being, and it impacts a person's social well-being. I'm sure all of us have seen patients who suffer from pain. In fact, some of us may have already suffered from pain in our past experience, and we know how much it impacts our own daily activities, our own emotional well-being. We may become nasty to people. I have patients who've come in and told me that the pain bothers them, and their children would say, little kids telling me, "Mom's been very mean to me," or "Mom's being very nasty to me." I'm not exaggerating, but these are real incidents where little children come and tell me how their mother has actually changed and become very, very tough, very mean to the children. So pain actually does a lot of things, not just to the physical person, but also to the emotional person. And because of all of this, it affects a person's social well-being also. Next slide, please. What is pain? Now, this is courtesy Dr. Rajobal sir. And pain is a sensory and keyword, and it's an emotional experience associated with tissue damage. So there should be something going on somewhere that is causing the symptom of pain. But whatever the person is experiencing is also modulated by the person's emotional experience. And therefore, different persons have different emotional experiences, the way they perceive things. So the experience of pain is subjective. When somebody complains about pain, this is the one of the most important things we all as caregivers should know, is that we should believe the patient about the pain. When somebody is telling, the first instinct for all of us as caregivers is to say, that's probably not true. It's unusual to have so much pain for this disease or whatever. But whatever it is, the first step to be as a useful palliative care professional is to believe the patient about pain. Next slide. So, what is pain? Pain is what the patient says it is. It is subjective. Different people experience it differently. And one person's report of pain may not be the same as another person's report of pain. One person's severity of pain may not be the same as another person's. Now, the challenge for all of us and the caregivers is to take care of patients without our own biases being imposed on their pain or their painful situation. And once again, I'd like to report the person's self report of pain is the single most important indicator of the pain. So if a person says, "Oh, my pain is excruciating," we just have to believe them. And that is the most important thing. We have to believe them. So what are the psychological factors? Next slide. What are the psychological factors that can actually modulate the pain and the pain thresholds? Emotions, cognition, or the knowledge, or the awareness of a person, or the emotional setup of a person, the personality of a person. Like, if the person thinks is of a stronger personality, or rather a dynamic personality, you may see that they probably handle things the same. Well, it's actually not true. I've seen patients who are very dynamic suffer from more painful experience than someone who's actually very, very non-dynamic. So every person, regardless of how much their personality is, can experience pain. The psychological factors modulate it. Some patients have good coping techniques. Some patients, at the same time, may increase their pain experiences. It's something called illness behavior. There's a lot of factors that can play into the experience of pain. Next slide. As a doctor, how do I know if somebody is having trouble with pain when they can't express themselves? One of the key factors that I check is heart rate. Usually, when a person is in pain, their heart rate will be higher than normal. That's something that I really assess on a clinical condition. If somebody actually is unable to express themselves and has a lot of physical features, high heart rate, is moaning, groaning, grimacing, all of these things, restlessness, crying, these are all sort of indicators that they are suffering from pain. And they also may actually okay, they actually have trouble with the trouble with reduced social interactions. They may have trouble with behaving, with interacting with other fellow people. They may have trouble with eating. Some patients who have pain may just starve, who may decide to just not eat much. One of the key indicators of pain is sleeplessness. They may have a lot of trouble with lack of sleep because the pain is actually bothering them. Now, next slide, please. Next slide. Yeah. When pain is not treated properly, if we are not able to treat a person's pain properly, there can be a lot of health conditions. There can be a lot of problems as a result of that. Number one, poor appetite. A lot of patients would come to me and say they have poor appetite. If you dig further, you would know that their appetite loss is probably because of untreated pain. They may have weight loss. Some patients, like I just mentioned, have sleep issues. They can't sleep at nighttime, they can't sleep in daytime, or their sleep is altered. All of these things can happen. And when pain is not treated properly, patients can really withdraw from talking or their social activities. They can really come back and withdraw themselves from everything. Their social activities, they become depressed. A lot of depression, sadness, anxiety can develop. All of this actually feeds on top of the other. So it gets into a pernicious a cycle, one feeding onto the other, and untreated pain leading to social withdrawal leading to a lack of coping strategies leading to anxiety inevitably leads to depression and sadness. So, and that all again feeds into the pain itself. So you see how a small beginning of a pain can actually impact the entire person's physical, emotional, and social well-being. Some patients actually show a lot of aggression. They have they act out, they resist care. Like I was just talking about, I have patients who actually come and talk to me about aggressive behavior. In fact, some patients have told me I've been very nasty to my children. In fact, one patient I met yesterday, her caregiver confidentially discussed with me that the patient, who also is a nurse, actually has been very aggressive and is very, very, very much mean to everybody around her, unusually over the last couple of days. And then I had a chance to sit with the patient and talk in private, and I realized that she was suffering more pain than usual. So a lot of this actually leads to aggression, acting out behavior. Sometimes people may misperceive this. When they actually see that patients are acting out or showing aggression, caregivers have a lot of trouble trying to adjust to that situation. They feel like the patient is dumping a lot on them. So it is not just affecting a patient, but it is actually affecting the entire caregivers, the family members, even a doctor. Sometimes the doctor may be confused too. Sometimes the nurses may be confused too. What is going on? So at the root of all of this could be an untreated pain. Next slide. So Dame Cicely Saunders is a nurse who actually was living in the 1940s, and she felt that medications and medical procedures and surgeries were going out of hand. A lot of the patients were really suffering in England at that time. So she decided to adopt something called palliative medicine. Now, she didn't believe in palliative care because she thought having the word palliative care, people will underestimate her. So she was a proponent of what we call palliative medicine. So she created a hospice in London called St. Christopher's Hospice. Some of you may know about this, Dame Cicely Saunders. And that's how the hospice movement started. Now, Dame Cicely Saunders has written a lot about pain and how to take care of patients with pain, and she defined something called total pain. And total pain is what I've been talking about all of till now. It is that it is suffering that encompasses a person's physical, psychological, social, spiritual, and practical struggles. So one feeds onto the other. You see that Venn diagram. Person having physical struggles, pain, can actually feed on to social setup. They may have financial issues that may impact their care for their physical illness. So they may have emotional trouble that is accentuating their physical trouble. And amidst all of this, they may have deep spiritual issues too. I have patients who come in and talk to me about guilt. Why did I get this cancer at this age? Now, a lot of what I'm going to talk about will be from the setting of a cancer because I'm a medical oncologist. So a lot of patients have guilt. I am pushing my family into this kind of stage. So I am the problem. So a lot of patients can actually have significant guilt, and that guilt can add on to the pain threshold as well. In fact, right now I'm working with one of my students on trying to write a brief article about emotional well-being in cancer patients. And while I was writing yesterday, I met another person who told me that her mom had passed away 16 days ago with esophageal cancer. This person wanted to know if she was at risk. I said she was not at risk, but she then ventured further and told me that the mother actually killed herself because of untreated pain. So suicide in patients with cancer is not unheard of. In fact, it is something that we doctors who take care of patients with cancer are acutely aware of. So all of this is defined with the concept of total pain. Now, when this happens, our objective of treatment is not just pain relief, but we want to focus on the wholesome quality of life. That's why if you come see me with sometimes some issues with pain, I may not actually talk more about the pain, but I may actually try to understand more about the social aspects of pain, the social aspects of the suffering, the financial aspects of the suffering, the spiritual aspects of the suffering, because I know that untreated, all of this, if left untouched, the physical suffering will not be relieved. So you have to take care of all of this in order to take care of that physical suffering. So our objective of treatment as specialists in palliative medicine is quality of life, and it's not just one-dimensionally pain relief. Next slide. Next slide, please. Yeah, thank you. So one of the first things I'd like to point out as a doctor, one of the first things I think about when I see a patient is I always categorize the pain. So the first question that I ask myself is it pain that can be treated and healed, or is it pain that can be treated and palliated? Both are different. I'll give you a classic example. Toothache. If a patient comes to you with toothache, dental ache, that is incredible pain. In fact, toothache is one of the worst pains possible. One of the biggest reasons for narcotic abuse in the United States, which is where most of this data is coming from because it's been widely prescribed there, is in the setting of toothache. Because if a person comes to an ER, emergency room or casualty, in fact, I have worked in ER a lot, emergency room as a young doctor. One of the biggest problems that we see is patients coming with toothache. Thanks to electronic medical records, you can always look back and see where this patient has seen, which hospital they have sought care, how many casualties or emergency rooms they have visited, how many times these medicines have been used. So you can always have a control nowadays. It wasn't the case a few years ago. So whenever they come, the instinctive reflex thing to do is to prescribe morphine or some narcotic pain medicines. We have something called oxycodone there. I don't know if people have heard about that here. This is a different kind of a opiate narcotic. So because toothache is not something that you can measure, you have to believe the patient, and when they come, you tend to prescribe this. But nowadays, because you have all these electronic medical records, you can follow up and see who's actually having multiple visits, who's actually obtaining this from multiple pharmacies, who's actually going to my hospital, next day going to another hospital. So you can sort of understand who's feigning this or not. But if a person genuinely has bad toothache, it is something that can be treated and healed. Whereas there are certain kinds of pain that can be treated and palliated. I deal with a lot of breast cancer. So when patients with breast cancer have a mastectomy, that is, they remove their breast and then they have radiation to that chest, they have a lot of pain, the residual pain. It's chronic pain. So the surgery is disfiguring, but at the same time, the surgery cuts a lot of nerves and leads to a lot of neuropathic pain. Now, this is chronic pain. There's nothing I can do to heal, to cure that person's pain. All I can do is to palliate that person's pain. In fact, even to treat post-mastectomy pain is quite challenging. So whenever I see a patient, I always categorize pain into one of these. Sometimes we assume that a person with cancer has pain because of the cancer and can't be healed. That may not be the case. There may be patients with cancer, with stage 4 cancer, that may come to a doctor, that patient may come to a doctor with a pain that has a curable reason for the pain. I'll get to that soon enough. So you should not be blinded by a person's diagnosis. A person is a person. They're not a diagnosis. So whenever a person comes to see a doctor or a nurse or a healthcare professional, we don't label them into patient with cancer. We label them based on their name, based on their personality, based on their personality and personhood, and then evaluate them afresh. Just because they had cancer doesn't mean their pain cannot be healed. So always categorize into two and decide what can you do, because a lot of pain that is currently, in my opinion, that can be treated and healed are not treated and healed because we categorize patients into one or two. Next slide. And that is why I always emphasize on the importance of proper diagnosis and proper treatment. A proper diagnosis is something that's very important, and that comes from a couple of things. As a doctor, I always talk about how nearly 75% of my diagnosis comes from just talking to patients, from history and physical examination. So a lot of the time, out of our busy schedule, we do not talk to patients. So we don't get a proper history. There are a lot of things that a doctor should ask a patient. How did the pain start? When did the pain start? What aggravates it? What relieves it? What are things that you do to make it better? What are things you do to make it that makes it worse? All of these questions help a doctor diagnose the pain. And for that, sometimes you may need investigations, sometimes you may need treatments, sometimes you may need diagnostic tests, sometimes x-rays, sometimes an ultrasound scan, sometimes a CT scan to figure out what's causing the pain. So a proper diagnosis is very important to figure out the pain. The next one is access to proper treatment. A lot of the time, our patients don't have access to treatment. And this is where financial setup is a very important barrier to seeking access to care. In fact, Dr. Raj, one of his favorite things that I always remember is he always talks about how if a person is rich, they suffer the worst death in the ICU connected on the machine. The poor die quick without have access to pain medicines, but at least they may not be connected to ventilators or life support systems. In a way, that is true. But having good access to proper treatment, proper diagnosis, proper doctors. These are all crucial things. And this is where the financial barriers can sometimes hurt a person. Next slide. So I talked about how access to care is important, how proper diagnosis is important. So how do you treat pain? I talked about how a doctor classifies pain into two: some things that can be treated and cured, something that can be treated and palliated. Surgery can sometimes heal a person. Like I said, toothache, you do a root canal, or you just take the tooth out, and that can actually cure the pain. That's called a surgical management of pain. Sometimes a person with incredible pain from a gangrene can undergo amputation and can have incredible pain relief. Just this week, I saw a patient with incredible pain in the knees because of significant osteoarthritis, and I recommended that she sees a surgeon for consideration of total knee replacement. And from talking to patients who've undergone that, I know it's a heavenly feeling to have an artificial knee in there if they have such severe excruciating osteoarthritis. So sometimes pain can be relieved with surgery, and sometimes pain can be relieved with some procedures. A classic example is pain from pancreatic cancer. If a patient has a pancreatic cancer and a lesion that is actually uh, touching the nerves in that area where the pancreas is located, one of the the central points of a lot of nerves in that area is called celiac plexus. So if a doctor thinks that a person from pancreatic cancer is suffering from a lot of abdominal pain, that can be relatively easily palliated with a procedure called celiac plexus block. That is, a doctor will put a tube down the throat, go all the way down to the stomach, down to the duodenum, and will inject some local anesthetic to the area where all these nerves pass. Nearly 50% of the patients with pancreatic cancer who have pain because of the mass touching on these nerves get quick pain relief as a result of celiac plexus block. So there are some procedures that you can do to cure pain, that is the surgical steps. There are some procedures that you can do to palliate pain. And there are some medications that you can use. There are some topical medications. I know you're familiar with some of these options. There is, you can use Volini or Wolverine. It's a local application. There are some knee pains. You put the different formulations that will help topically on the skin. There is some parenteral approach. Parenteral approach is oral morphine. There are IV morphine or intramuscular options are there. Subcutaneous delivery of a narcotic is there. There are different ways you can approach pain. It is important that we actually seek the help of integrative medicine specialists in some setup. I'll give an example. In breast cancer, again, there are some cases where if patient have significant mastectomy pain, you can try acupuncture. And in some patients, the acupuncture helps relieve their pain. I don't know how it does. I don't think anybody knows how it does. But hey, some people it works. What works for us too, right? As long as the patient gets relief, I'm happy. So sometimes, as doctors, as modern medicine specialists, or we do really have to think about integrative medicines. Ayurveda massages can sometimes help. Stretches can sometimes help. Sometimes supportive care, splinting, bracing. If a person has a lot of pain because of compression fractures from metastatic cancer in the bones, if you brace her entire bones in the spine were broken with cancer, and she was actually taking uh, about 100 milligrams worth of oral morphine equivalent every 6 hourly. Would you believe it? So that's like 400 milligrams of oral morphine equivalent, and still in pain. So we talked about how she can be, we kept a TLO brace, a complete brace, and that actually relieved her, and so much so that she was fairly active in her wheelchair, of course, but she passed away in comfort with sufficient pain control. Let's not forget about psychological care. A lot of our patients need counseling. A lot of them need therapy. And I mean, I'm not an expert to talk about that to this group, but the importance of psychological care, counseling to patients, just talking to patients is very, very important. And finally, next slide, please. The most important thing is simply to listen. Now, this is something that is in short supply in today's world. You know it, I know it, all of us know it. We are all short on this skill, listening skill. We talk about oratorical skills, speaking skills, personality development skills, but nobody talks about how to improve their listening skills. So the most important is, if you see a patient or their caregiver, listen. In fact, there are studies from the US that looked at how quickly did a doctor interrupt a person, a patient, when they actually stepped into their doctor's clinic to talk about their complaints. And I believe the study showed that it took only about a couple of 8 seconds or 10 seconds before which they interrupted the patient from describing their problem. So I mean, I do it. I'm guilty of this as well, because the clinic times are short. You want to rush to the next patient. You have some preconceived notions about certain patients, and you feel that they're going to talk long sentences. So as soon as they start speaking, all right, tell me more about the pain. You just interject. But really, the most important step is actually to listen. Next step, next point, next slide, please. Talking about medications that you can use as a doctor, I always think about it. Always treat pain early. You can't really wait for the pain to get worse before we start treating them. Treat pain early. Palliative care medicine specialists who are experts in pain and pain management would always talk about how untreated pain initially will recruit a lot more nociceptive stimuli, nerves, into the pain cascade, and actually can worsen the pain. So if you treat pain early, you may actually need lesser pain medications than if you wait for pain to be treated at a later stage. In patients who are getting continuous pain, analgesics or medication should be given on a continuous basis. I'm surprised every time I see patients admitted in the hospital with cancer, for instance. That's the patient I see. Pain is very much undertreated, and sometimes just a simple step is more than sufficient. I'll give you an example. I visit a hospital 1 hour from here where I practice. That's another setup I practice. And in that hospital, once I admitted a patient on Monday with pain issues, chest discomfort. I sort of guided the doctors what to do. I left the pain management to them. This was a new hospital I was visiting. 2 days later, I went back to the hospital and I saw that the patient is still in pain. I asked them, the nurses, what medicines they're giving. Really nothing. So all I did was put her on paracetamol 1 gram, PO, orally, scheduled round the clock. So once every 8 hourly. Then next day I called them and the patient is incredibly much better. So simple interventions. If a patient is having continuous pain, analgesics round the clock based on duration of pain. As doctors, we always underestimate this, but it's actually quite important and will help palliate a person very well. We all know about analgesic ladder. We have talked about it. Next slide, please. WHO has brought about this ladder of analgesia where you actually give medicines by the mouth as long as possible. If a patient can take it by mouth, give it by the mouth. Give it in schedule, by the clock, by the ladder. So start with a non-opioid, start with adjuvant strategies, whatever can help. The word adjuvant means in Latin to help. Whatever can help a patient. It could be counseling, it could be topical ointments, it could be it could be some other medicines, not pain medicine, something else that can help. So some depression medicines can help. So anything that's adjuvant. And if that doesn't help, you step up to the next ladder, a weak opioid for mild to moderate pain. If that doesn't help, you go to a strong opioid for moderate to severe pain. So this is something that is commonly used by palliative care medicine experts and doctors. I use it sometimes, but I don't think about the ladder all the time because now it's sort of become practice for me and I can gauge the pain. So there are some patients who come to see me in clinic who I know are suffering from severe pain. I don't step up from the ladder. I just go straight to the tough one because I know I need quick pain relief. So I do go straight to the bigger ladder based on experience. So next slide, please. So that's briefly about pain and what I perceive as its impact and what we can do. I'd like to give you a few examples because I think examples are really what matters and will really help convey what I'm trying to convey from all of the slides. So case number one, I was seeing a patient in my cancer clinic recently, and the patient is well known to me. This time when the patient came, she brought her maid along with her. And the patient actually asked me, "Doctor, this is my maid. She has incredible pain. I'd like to." We saw another doctor, and the doctor recommended CT scans of the head. She has headache. And I said, "Okay, let me examine the maid." So my patient stepped out and the maid stepped in. And I asked her, "What's your pain?" And she said, "My pain is in the head." I asked her what side of the head, and she pointed to the side. What time of the day? The usual questions that every doctor should ask, which is why I'm been talking about how it's important to listen, how it's important to ask the right questions, because taking history taking will give you more than the diagnosis more than 75% of the time. And I was reasonably sure she's suffering from sinusitis. So then examination adds the next 25% of my diagnosis. So I pressed her sinuses and she had tenderness. So I skipped the CT scan, which was going to cost 4,000 rupees. I went straight to management of sinusitis. I just advised her to do daily steam inhalation twice a day and take paracetamol if she hurts and tell me how it goes. So 10 days later, I met the patient at her house because I go to the house once in a while. I asked the maid how she feels, and she said after years of suffering from this headache, she feels incredibly better. So simple intervention, history taking, a proper history taking, a relevant examination. So again, coming back to what I was talking about, a proper diagnosis, proper test will help you get to the diagnosis, will help you figure out if it's a pain that can be treated and healed, and a simple intervention. She didn't need paracetamol, all she needed was steam inhalation and good counseling, telling her that steam inhalation is all probably what you need because it's free of cost. Don't underestimate it, because a lot of her patients underestimate steam inhalation because it's free of cost. If I probably charge them 1,000 rupees per steam inhalation, they'll probably do it on the clock, on the schedule. But because it's free of cost, nobody does it. So I counsel them, please, steam inhalation is very important for sinusitis, do it. And she found immediate relief. So next slide, please. So this just illustrated how I can treat and cure patients' pain. Now, just because it's sinusitis pain and headache, don't underestimate it. It's an important thing that affects a patient's quality of life. Case number 2. I have a person with headache. Now, this person is a young woman who came to me, and she has progression of her disease. She was on a treatment, but the treatment didn't help. Her cancer progressed. And this time she came to me and said she has extreme headache. So I try to listen to her. Okay, what's going on? Is there headache? Is there vomiting? No. It's just headache. I asked her what makes it worse. Well, doctor, it just started recently. So clearly there was something that's actually started recently. So I didn't have a lot of history. I didn't have a lot of clues from the history, because this is a patient with cancer. This is a patient who's had progression of her symptoms. So clearly I'm worrying about something in the brain that's causing the headache. That's my worry. But I decided to do an exam. One of the most common reasons for headache is tension headache, stress headache. So all you got to do is just stand up, go to their backside while they're sitting, put your hands on their shoulders, and just examine for swollen muscles, tender points. And this patient, lo behold, had a very nasty tender point. So she had a classic feature of tension headache. So it's very important that just because we have a patient with cancer, we don't label them as so and so with cancer and treat whatever symptom they come as cancer related, but label them as their name itself and treat whatever they have as a new symptom and evaluate afresh. This patient had tension headache, although she had progressive cancer also. So I asked her to do warm compresses. So the other way, I was talking about steam inhalation. Now here I'm talking about warm compresses. Warm compresses, gentle massages, free of cost. She did it. Her headaches are much better now. So proper diagnosis, proper investigations, proper tests, and trying to identify, trying to listen is all helpful. Next slide, please. Case number 3 is a patient with stage 4 colon cancer. Now, this is a patient. This is the maid's help. The first case I was talking about a patient. This is that case. So this is a patient with stage 4 colon cancer who's really well attached to me, very much linked to me. Her ups and downs are closely linked to me. So she complained of pain in her right upper quadrant and left lower quadrant. So abdominal pain. So I go examine her. I get a history, no clues. I do a examination, no clues. I've recently done a scan. Her cancer is relatively okay. So I did my counseling. I did my thing with my words. I told her, man, I call her Amma. Amma, your cancer is fine. You're doing well. This is not cancer related. This is really okay. And the next moment, she was fine. So a little bit of counseling, a little bit of this will really help. And that, sometimes patients have to hear it from their doctor, because sometimes it's the doctor that they trust. So sometimes they really have to hear it from their doctor. I work very closely with psycho-oncologists in my erstwhile practice in the United States. So, they see patients. We have this distress thermometer. So if the distress thermometer, I don't know if you have heard about it, if there is a scale of thermometer, like a scale, if it reaches high score, then they reflexly request the consultation from a psycho-oncologist. So the psycho-oncologist goes, sees the patient, they come back, they talk to me, Dr. Matthew, we saw the patient, but really what they need is you. Sometimes psycho-oncologists can help. Sometimes it's the other way around. They probably may not confide in me, and that's where psycho-oncologists, which are trained counselors, can really guide patients into understanding where their cancer is, understanding their problems. Next slide, please. Now, this is the daughter of a high-profile patient that I have, which is very, very socialite patient. Obviously, when patients are VIPs, there's a lot of dynamics that come into play. There are too many doctors at play. There are too many experts. There are experts from all over the world at play. There are well-wishers. There are other VIPs, all of these things. So this is a daughter of a patient with brain metastatic. So then the daughter, the only person, the doctor, she trusts me. And the daughter is young, therefore the family doesn't pay much attention to her words. So now this person, she's dying, and while she's dying, she's on morphine round the clock. And the daughter is happy that her pain is under control with scheduled dose morphine. And this is where you have to talk about the caregiver, because for the caregiver, for the daughter, nothing matters as much as seeing their mother in comfort. Before that was going on, at least until I can give you 100% my guarantee, until a properly trained palliative care physician was on her case, there was zero comfort. There was zero comfort for her pain, and the daughter was suffering, seeing her mother in pain. Once a properly trained, very careful, astute young palliative care medicine was involved in the case, he spent 2 hours listening to the patient, taking care of the patient. The daughter, the caregiver, grew comfortable after seeing her mom gets comfortable. So a good palliative care physician can take care of not just the patient, or a palliative care professional, a counselor cannot just take care of a patient with pain, but also the daughter with the pain. Now, the reason she called me was the patient's family member from abroad has come and has altered all the regimen, and she's back in pain and was asking me, out of frustration, doctor, what should I do now? My mom is back in suffering. This person has come and changed everything, but he's senior enough, I can't do much about it. And I asked her, how long is this person here? For one more day. I said, it's okay. Just hang in there for one more day. We will get her back on her schedule. And don't worry, I assured her that I'll get her back on her comfort, and we'll work with the palliative care doctor for that. So sometimes taking care of the caregiver is very important. In patients that I see with stage 4 cancer, I put exceptional importance on caring for their caregiver. A lot of the time, there is published literature about it. A lot of the time, 6 months from the death of a loved one, there is incredible guilt that a family member can go through as a result of various emotions. Did we give up too soon? Did mom suffer? Did dad have a hard time? Did I cause all of this? Did I do all that could have been done? All of these emotions come to these patients, caregivers. So you have to take care of their caregivers also. Don't ever underestimate the caregivers. Case number 5. I think coming to the end, case number 5 is a man with prostate cancer. He's now cured. He comes to my church, so I see him at church also. So every time I see him, he tells me, doctor, I have neuropathy. He doesn't tell me he has neuropathy. He tells me he has tingling in his arms, hands, and feet. I asked him, uncle, is it time for you to start some medicine? I have something I can try. He said, no, let me see. Finally, a few weeks ago, he said, yeah, I think it's hurting me. I'm having a hard time sleeping. So I put him on neuropathy medicine. Next time I saw him, he said he feels better, although the sleep is not as perfect as before. So I switched his medicine. Instead of giving the medicine in the morning, I added the dose to the night time. The next time I see him, he's having comfortable sleep. So right, so how, you see how even cancer survivors, patients who have cured cancer, have complications of treatment and needs the support of doctors, of nurses. Sometimes they underestimate it. Sometimes they think, okay, my cancer is over, now I don't have to see a doctor, I don't have, there's really nothing I can do. Like the mastectomy pain, the patient with mastectomy pain, unfortunately for them, there's very little I can do. But for this chemotherapy related neuropathy, there are things that I can do. Next slide. What are the barriers? The barriers are patient tolerance. Like I was just talking about, this patient may have thought, okay, I had cancer, some degree of pain is expected. It's okay if I don't sleep, so I can just tolerate this pain. So patient tolerance, patients coming to doctors seeking help and saying, I need help, I can't sleep. Do you have anything? So patient tolerance can be sometimes a problem. Caregivers can positively or negatively impact. The same case number 4 I was talking about, the daughter really positively impacted the comfort of her mother, but another caregiver negatively impacted. So caregivers can be barriers. The next point is financial resources. It's a reality. Those who are affluent, those who can spend money, can get good doctors care, have their time, can get palliative care resources. But thanks to good movements like Palim India and other movements such as this, we are trying to get palliative care to regardless of, irrespective of their financial resources, to people. And the last point I would like to talk about is resistance from doctors itself. We have a lot of ignorance. Doctors, we don't know. I mean, I'll give you an example. My aunt was suffering from cancer and was in a leading hospital with a very specialized palliative care team from years. I was calling from the US. I was practicing there at that time, and she was in pain, sort of end of life. And I talked to the doctor at my midnight, like 2 a.m. in the morning, early morning, and then, I pleaded with the doctor, please give some more pain medicines, please increase the morphine. And the doctor got back to me and said, the morphine, I think we have a barrier. I think he used a word. We have reached the ceiling, or what? He didn't use the word ceiling. If he had, then I could have taught him something then. But he said patient will have respiratory depression. So ignorance from doctors. In fact, there are studies that looked at how much ignorance exists with doctors and medical students, and that can be a barrier. Lack of incentives. These are not medicines which provide a lot of incentives. So to prescribe, listening doesn't give you more money. So listening to patients may actually take your time. The pressure in a busy practice setting. A lot of our government cancer centers are overburdened with patients, with volumes of patients. So the time is a factor. The burden of doctors is a factor. So healthcare professionals, and this is where all of us can actually. Can you hear me? I hope you can. Okay.
Yes.
Yes. Okay. So the last slide. Next slide, please. Last slide. Here's where you can help. Like I always talked about, listen to patients. Talk to patients, family members, caregivers. Always emphasize multidisciplinary care. There are certain things that a doctor can't pick up where a psycho-oncologist can help, a social worker can help. There are certain things that I as a doctor don't know. How can I get resources, financial resources for a patient? A financial counselor, trained social worker can really help in that kind of setting. I don't know what schemes are available for patients. I don't know how to get below poverty line ration card stamped. I don't know how to change all of these things. And I don't really have time to take care of that. Whereas a social worker doesn't have time to talk about medical investigations or tests. So it's something that, I'll do what I'm best in. I'll have to find people who are good in what they're doing best in. We have together focus in multidisciplinary care. Always ask questions. Even if you as a healthcare professional see patients who are already seeing palliative care doctors who are not, or oncologists or other doctors, and patient is not comfortable, ask questions. Is the doctor missing anything? Or is the nurse missing anything? Are we missing something? Always be bold, ask questions. Ask questions from doctors, and never underestimate pain. No, never ever underestimate pain. thank you. And I think I stopped on time, and I'm happy to do whatever is answer questions or stay. I must admit that I'm really not an expert in a lot of I think the psychosocial aspects. A lot of this is from my experience, but I'm here to learn as well.
Yeah. Thank you, Dr. Raju, for this wonderful session. All the things you explained from your real life experience, that is more related to us also. So thank you so much. I think Ms. Smriti Rana is here with us. So she also want to add some points, I think so. Over to you.
Absolutely.
Thank
Absolutely, Smriti.
Thank you, Raju. Thanks so much, and thanks everybody. There was a very deliberate reason in asking Dr. Aju to do this session. And it might be a question that is in some of our minds: why is a psychosocial session being led by a doctor? It's because, like we said in the beginning, that this is an interdisciplinary approach. Palliative care prides itself on its interdisciplinary approach. A lot of the things that Dr. Aju spoke about today, I think, was beautifully expressed in non-medical jargon, because the rest of us didn't go to medical school. So it becomes easy when somebody presents these kind of things to us in this manner. And I think the risk of being in an interdisciplinary team sometimes is that we only operate in our own compartments. So a psychosocial clinician will only do what a psychosocial clinician is expected to do. A doctor will do only what a doctor is expected to do. But I find that in my practice, it's really important for me to understand what at least not in a way a doctor will understand, but at least to understand how certain symptoms present and the impact it can have on that person. And I think Dr. Aju touched upon a really, really important concept, which is that one of total pain. The experience of pain is determined by what is going on in a person's life at that time. And I think there's enough evidence to demonstrate that. I mean, right through Dr. Aju's case presentations, I mean, that became abundantly clear. So if somebody is telling you that their pain is 9 on 10 on the pain scale, they may not show some of the physical symptoms that we have over the years been conditioned to associate with that kind of pain. But then that begs the question, what else is going on in this person's life that is causing him or her to experience this pain so intensely? And I mean, I don't know if I've done that headache exercise with, I can't remember. But, I mean, if you are to imagine having a headache, and if you're having a bad day, that headache will feel much worse than if you were having a nice day. And I think I've mentioned this example before. And that applies to almost any kind of painful or distressing physical symptom that you have. So there is an overlap. Now, what is the difference between an interdisciplinary team and a multidisciplinary team? There is overlaps in an interdisciplinary team. So I need to know from the doctor of the team how this pain is going to manifest, and then what are the psychological effects of that pain. Now, Dr. Aju also mentioned sleeplessness, anxiety, depression, and all of that could be linked. So it's very important for us as non-medical clinicians to understand that the source of the pain or the source of the distress or anxiety might very well have a physical source. I feel that what has also really stood out for me today, Dr. Aju, is the humility with which you have expressed your opinions and your views, because it's not often that we hear doctors say that sometimes we have to admit that we're wrong. And I haven't come across too many doctors who have said that so comfortably, and I have to appreciate that you did. And also to recognize that there might be strength in an integrative approach, and not just medicine. If it can't be healed by medicine, it can't be healed at all. I mean, that's not how real life shows us it works. And I'm really, really glad that you pointed that out through your examples about integrative medicine and Ayurveda and acupressure, and even looking beyond what would normally be your own comfort zone. And finally, I just want to say that, well, two things. One is that you emphasize the importance of listening, and the other thing you emphasized is not everything needs to be solved through machinery and tech, right? I mean, sometimes you just need to touch your patient or to ask them the right questions, and then you understand what is really ailing them. And that is actually a more powerful way of connecting with the source of their pain
than an MRI could ever do or a CT scan could ever do. So thank you for raising that point. And simple interventions, yeah, I think there is elegance in simplicity as well. And sometimes we complicate things more than they should be complicated, but very often the answers are staring us in the face. It's just that we haven't asked the right question. And lastly, thank you very much for bringing up the plight of the caregiver and the pain of the caregiver and you know the dynamics within a family, within a caring system really impact the way a person experiences distress. And it's not just the patient but the caregiver as well. And uh, the thing you said about the fact that a bereaved family member can feel guilt up to 6-7 months or more. Like, I know people who felt guilty almost all their lives after their loved one has died. It's because nobody really took the time to help them navigate that while the person was still around. So it's very important to we have the power to preempt the emotional pain of the family, even if we know that the person that they love is probably going to die sooner or later. But we have that ability to preempt emotional pain in the people who will survive that person. So thank you very much for raising that point. And yes, now over to our case presentation. I think Divya is making the presentation. Thank you.
Yeah. Is there any comments and any clarifications needed from the participants? You can raise your questions. Yeah, Pranab Kumar sir.
Am I audible?
Yes, please.
Actually, to my mind, the patient involvement in activities that bring joy to the individual's daily life helps in moving beyond the constant presence that pain has in personal life. Actually, in my family case, I saw that my missus, who was suffering from metastatic colon cancer, she used to listen to the music. She used to read storybook while pain was moderate, and when the pain was severe, she used to take medicine. So in that way, this system, this personal choice, can help the pain to soothe, isn't it?
Yes. Thank you so much, sir. Thank you so much for mentioning that personal choice thing. Is there any questions? Vidisha, do you have to say anything? No. So I hope there is no further queries or clarifications needed. So we can move ahead with Divya's presentation. So Divya is a counselor in palliative care. She works in Swami Vivekananda Youth Movement. So thank you, Divya, for doing this wonderful thing for us. Thank you so much for finding time to do the case presentation. So over to you.
Good evening, everyone. Dr. Raju, thank you so much for such a wonderful presentation. I had a lot of doubts regarding pain, and which definitely you cleared a lot of my questions which was there, and I understood everything, and so I have no doubts. So can you start with the slide? So we had a patient who was 38 years old with carcinoma of distal stomach with liver metastasis, and the histopathology reports were the type of ulcerating, diffusely infiltrating adenocarcinoma, and actually the patient is no more with us. He died very recently in this month of 12th, and these were all the medications which he took, and he had terrible pain maybe after second cycle of chemotherapy, which were it was managed well. Pain management was quite good with us. Next slide, please. And this is the genogram. The patient lived with, it was a joint family. So that's the patient. So he lived with his parents, his wife, and the 3 children. And he also had a sibling, a younger brother, and his wife. So they all lived together. It was a joint family. And yes, he had a very good relationship with all of them, but all of the other family members. But yes, he had a very cordial relationship with his wife and children, which is very common. And there were no other disturbances or conflicts. Not yes, there were conflicts which were very trivial, but not of that importance. Next slide, please. So this was the illness history. In the month of March 2019, he was diagnosed with CS stomach. And immediately after the biopsy reports were obtained, chemotherapy was started. And the patient got registered with our palliative care in the month of June. Actually, the 2 cycles of chemotherapy he had taken already. It's a mistake. I think I mentioned only 1 cycle. So 2 cycles were already over when he got registered with us. Next slide, please. So this is the family history, which I mentioned a few minutes earlier. He lived with his wife. We had 3 daughters, his parents, and brother and his sister-in-law. And I told you that there were few trivial conflicts with his mother, but all the other family members were very supportive throughout. Next slide, please. The social challenges was, even though they were very supportive, financial support was not obtained, especially from the other family members and relatives, even though they all visited the patient frequently. So that was a little challenge. And the social support available, where the patient had umpteen number of friends. He had a huge number of friends, because we had seen all the friends visiting when he got admitted in our palliative center. And they all were very supportive with emotional and moral values. And he always entertained them. And yes, of course, the religious organization were of good support. And from our center, we supported with the pain management, the medical aspects and psychological aspects were managed. The financial condition, the status was like, he was a little worried about the kids' studies, because he had 3 daughters. The elder one was just around 12 years or 11-year-old. The younger one was 10 years, and the youngest was just 6 years old. And he was little worried about the students, the children's admission fees and so on, because it was in the month of March he got diagnosed with this illness. And by June, we all know that the school reopens, and that for that thing, his mother had offered some financial helps, and that was clarified for a while. And the patient had no debts or nothing like that. And the scheme he availed was Ayushman Bharat Arogya Karnataka, and it was claimed. And once it was claimed, the treatment had started, and no other financial constraints were there within the family. Next slide, please. Yeah, the education status, as I told, the elder daughter in 7th grade, the younger in the 5th, and the youngest in the 1st grade. And job status was, the patient's mother had a petty shop. The parents used to run it, and brother had a small-scale business. And the patient was working as a taxi driver in the Bengaluru city. So until diagnosis, and later on, we all can easily guess what happened. He was the breadwinner for his family, and that stopped completely. And patient and caregivers' insight on diagnosis and prognosis, they all were very well aware of it. It was the mental status examination. This thing, what I mentioned was, during the first admission, and after that the patient had 3 more readmissions, which I have not mentioned. So this mental status examination, which you can see of the patient, was during the first time of admission. So appearance, grooming level of alertness, emotional and facial expression, attitude towards the examiner, you can just see there. He was moderately nourished, well dressed. He was tired always. And yes, he was very anxious, but he was very cooperative with all of us, all the team members. And the caregiver, they all look very nourishment wise, they all were very healthy. They all were alert, hygienic. And yes, they all were anxious because of the sudden things which happened, because they had some other plans, because it was March, and they had some festivals to be celebrated within the family, and everything just went upside down and these things. And but they all were very cooperative with us, and yes, they were anxious. Patient's behavior, he always maintained eye contact, because he was a good guy actually. He was handsome, and he was a very strong-willed person in spite of all sort of terrible pain and such a diagnosis in his life. And the caregivers were also good. They used to maintain eye contact and all those, yeah. And then speech, it was decreased and soft due to pain. And whatever he spoke, he was very clear about it. And when I used to speak with the caregivers, especially his mother and wife, yes, they used to just break down while explaining all their issues. And patient's mood and affect, anxious and worrying about his kids, about the future, and at times he used to feel hopeless. But he had that hope about the treatment modalities. He used to trust it. I'm saying that he used to trust, because I'll just explain the coming slides. And likewise, the caregivers were also very anxious, but they were hopeful about the treatment, because immediately after the biopsy reports were obtained, the treatment was started, and we all had a very good, we all were hopeful about his outcome of the treatment. Thought process was organized, content also. Cognition, he was conscious and oriented, and same with the caregivers. And insight and judgment was normal. Next slide, please. The psychosocial assessment major concerns, which I mentioned you earlier. The patient had accepted his illness, even though it was a shock in the beginning because of the sudden, because he just had a small stomach pain, which ended up with all those terrifying diagnosis, CA, distal stomach with liver metastasis. But he was, yes, confident with the treatment, which I told you. But his level of confidence started deteriorating, because when he was addressed from one of the staffs in the hospital where he used to get treated, that guy said, it seems, that see a stomach and you are done. You're not going to recover, and it's over, your life is over. Some guy spoke with him like that when he was waiting in the hospital for his second cycle of chemotherapy. So from them, as per our observation, he totally lost whole hopes, and he was like very much depressed when he came to us after the second cycle of chemotherapy. He told that nothing is going to work. I know that I'm done, because some of the hospital staff in the hospital where I am getting treated, he himself told this thing. And so I have no hopes. And gradually, he fell into depression, and also, like, all the adverse effects of the chemotherapy furthermore worsened the situation. And he used to complain pain all the time, But yes, we were able to manage it with the medical advancement and the medicines what all were available with respect to pain management. Yes, he was comfortable, kept comfortable, but still his mind and his thoughts and everything was like into hopelessness and other concerns about his youngest daughter had a congenital cardiac anomaly. I have mentioned it, the atrial septal defect, which needed a surgical correction. But he himself was not feeling well, and all these things had happened, and he was unable to take his daughter to cardiologist for further consultation and for the surgery and things. And his wife also needed a surgical correction for her prolapsed uterus. So all these things like devastated him. Next slide, please. So we are trying to help the patient realize his own strengths and such that he can cope with the whole process. But gradually, when we all fail doing it because of that incident, I don't know, because of that, to blame them, or because when he came to us during the initial days, he was very hopeful, and that brightness we could easily see in his eyes, which gradually went away, faded away. And the other goals were to help him understand the advances in the treatment and to trust the treatment. But unfortunately, he took 4 cycles of chemotherapy, but the treatment never responded, because after the 4th chemotherapy, he ended up with severe jaundice. So all these days, I mean, he was with us for almost 1.5 months, not continuously. He used to be with us for 3 to 4 days, maximum 6 days. And then he used to get back to his home. And then whenever he used to feel that pain or terrible feeling, he used to come to our palliative care center. And then we all as a team used to speak with him, try to convince him and understand and just to trust. But after the 4th cycle of chemotherapy, his blood reports were really a shock, a great shock for all of us. He ended up with severe jaundice, and because the treatment never, I mean, his body didn't accept or something like that. All these things happened, and we were not able to convince him, because even our hopes started fading away with his survival. And what happened was we started him to prepare him to the end of life counseling, and present goals of our psychosocial care is to follow up with his daughter's and wife's health as well. Bereavement counseling is going on, and social entitlements, example, the widow pension for his wife, and meeting with the patient's father exclusively, because why I have mentioned is this. This is related to the patient's wife. I think it's because of their cultural issues and some things like that. The patient's father is not willing to send his daughter-in-law for 4 months and 10 days outside of the house, or he has ordered not to enter out of the house, and never to meet any other male persons until it's been 4 months and 10 days of his death. I mean, from the month of July 12th till August, September, October, and November, maybe another 4 months and 10 days, she's not allowed to step out of her house. And so we are in deliberate thing, like we are, today we plan to visit his house just to convince him, or just to have a casual talk with the patient's father related to his daughter-in-law's health condition, because she needs surgery, needs an emergency hysterectomy. She's not at all able to sit. She has been going through a terrible time right now. She lost her husband, and she has a younger daughter with such a huge hole in her heart which needs correction, and she herself is suffering with so much of pain and things which she's not able to understand. But today, unfortunately, it was Friday and we were not able to go because when we called up, they said that the person is not there at home. And right now we have planned visiting him the next week so that these things get sorted out easily. Next slide, please. Yeah, next slide. So I'd like to discuss the miscommunication which happened when the patient was in the hospital to take his second cycle of chemotherapy. The one staff who said those terms which I had mentioned, that it's CS stomach and you are finished. So that had a great negative impact on this patient. And what happened was, and also altogether the treatment didn't respond to him, and everything was upside down. Even our hopes went away, and when the patient himself, he was not at all ready to listen to any of us. And so I think we need to discuss steps to avoid miscommunication and focusing in convincing conditioned mindsets. The conditioned mindsets I mentioned about the patient's father, or about his conditioning and some other cultural beliefs which the female lady is suffering right now, because she is unable to get her prolapse thing get corrected because of such conditioned mindsets. And effective bereavement support and access to social entitlements and resolving health issues within the family effectively. So if you all can put some steps, I mean, give me some ideas so that how to convince that person to solve these things in an easy way, that would be of a great help. And thank you so much for giving me this opportunity to present this case. I really become very emotional whenever I think of this patient, because he was very much connected with all of us. Whenever patient's father, so that at least I will be able to convince him for his daughter-in-law's surgery. So if she becomes better, then she can easily take care of her daughters, and the younger one also needs surgery. So please give me some ideas. Thank you so much.
Thank you, Divya. Hope our participants have many ideas to deliver. Is any comments? Ajay sir, would you like to add something?
Well, it's a very challenging situation. What, can you hear me?
Yes, sir.
Okay, it's a very challenging situation what Divya was talking about. All of the situation, I don't really understand what the father-in-law's problem is. I don't understand the condition thing. I didn't get it, the entire situation. I can't get it. I can't understand it. But I'll talk about the lack of hope issue. Okay, this is something that I face every day in my clinic. In several levels. One level, patients will come to me and say, this person has told me I'm going to die, and then I'll have to either give them confidence and boost them up. But in the back of my mind, I know that it's probably true. The chances are metastatic gastric cancer, 6 months survival is worldwide the commonest thing. 6 months, 6 to 9 months is the time. So how do I handle such problems? So this is one thing I do. First visit, I don't break bad news at all. I give them a lot of hope. I give them, I'm there. I use a lot of words when I talk to patients. Some of the things phrases that I use is, whatever is going to happen, I'm going to walk with you. You're not going to be alone. I'm going to be with you. These are some phrases that I use with patients, okay? and touch a gentle smile on your face. Whatever is going to happen, you're not alone. I'm going to walk with you. Another phrase that I use sometimes is, I am your doctor. I know what's going on in complete detail. If there is anything going to go wrong with you, you will hear it from me first. Everything else, neglect. And believe it or not, patients like to hear those words, both these words. I thought Indian patients don't appreciate these words. Okay, I mean, I practice in the US, so I thought our patients are somewhat different. No, actually, no. Our patients are exactly the same as our patients anywhere in the West. Our patients love to hear these words, that a doctor will walk with me, that the doctor will be honest with me if the time comes, and the doctor is willing to fight with me as long as it can take. So this situation, if the doctor had probably told the patient, if the doctor knew about the hopeless situation that just came about, then I think these words could be used. But sometimes patients don't open up with the doctors. They may hear all these random things, but they don't discuss this with doctors. These are some of the barriers that I was talking about. Sometimes that is because of the doctor's own time constraint. Sometimes it's their lack of communication skills, lack of training in how to communicate, how to discuss. We just have to systematically address all of it, which is why I think having palliative care in our medical curriculum is going to be a game changer in being good doctors in this country. It's going to be a game changer. It's more than anything we have ever done till date. The rest of the things, really, I have nothing else to add. You've done a tremendous job, Divya. You've gone to such a great extent. Kudos to you. It's hard for you. I can sort of imagine what you're going through. But I unfortunately don't have any easy solutions for you. I'll wait for others to chip in if there's anything.
Divya, I'd like to add a couple of things to what Dr. Aju said. Well, of course, it's very reassuring to hear that from a doctor, but the majority of the people here are not doctors, right? So I'm sure the question is now, it's great when we hear that from a doctor, but what can we do? Now, a palliative care team, by virtue of being a palliative care team and being interdisciplinary, we develop a bond with the patients coming into our care. Usually they've been knocked around the system quite cruelly, and then it's usually in the palliative care teams, when they come in contact with the palliative care team, that they're really shown humanity. They're asked their names, like, caregivers are, their needs are addressed and so on. Now, the same thing that Dr. Aju just talked about can be conveyed by us. We are also here to walk with you, right? And we are also here to be with you no matter what happens. Now, that no matter what happens is important, because we're not promising that they're going to get better. And I don't think it is okay to reassure anybody that things are going to be all right, especially when we know that they're not. Now, people tend to think very binarily about hope. Either you give people full hope or you take it away completely. No, you can reframe hope. You can reframe it to short-term achievable goals and wishes. Say, okay, fine, let's not talk about how long you will live. Let's talk about what you'd like to do in the next few days. So reframing hope is very, very important. And I personally do not condone the practice of telling patients and families that everything is going to be all right, because that would mean that we're not being entirely truthful. And that is not going to bode well for your rapport with the family and with the patient. So reframe the hope to make it short, achievable goals, and let the patient look forward to those kind of things. With regard to the father-in-law, this is a very tricky territory, because I could see from your response that you are, the whole team is quite attached to this family, right? So word of caution before going forward, clearly a lot of self-care is also required in the team. Because it's, when we get attached, of course, we do get attached, it's human nature, but sometimes our emotionality may cause another barrier in, when we're trying to help somebody solve a problem. We might want to solve it the way we would like to solve it for ourselves, rather than what works for the family. So it's very important to make that distinction. It's not what I want for the daughter, it's what she might want for herself now. So the first order of business, I think, would be to sit down with her. You're a woman, so you have access to her. I think the rules apply to male people for the next few months or whatever, right? So if you can get access to her, sit down and ask her what she wants and how she'd like to feel, how you can help her feel a little less stressed. Now, I'm not a doctor, so I'm going to ask Dr. Aju and any other medical people here, how urgent is the treatment for the uterus prolapse? I mean, is that something that...
Can I interrupt, ma'am?
Yes, sure.
I consulted one of our volunteer OBG doctor, and she said that temporary pessary can help with this case. So, and I actually spoke with, during the bereavement counseling on phone, I spoke with the patient's wife, and she is ready for the surgery, and she asked me requested me to convince her father-in-law regarding this. And it's because of their cultural issues, the religious aspects that is coming into picture, that he mentioned clearly that she should not step out of the house, and it's very clear, 4 months and 10 days, and she shouldn't face any males during this time frame. And
Yes.
so I consulted this doctor, gynec doctor, and she said that she can come over, make a home visit, and I mean, take the measurements of the prolapse and things, and then can go. I think it's a pessary or a tampon can help. She said, if it's within the, I don't know how to explain it. If this thing is okay with the pessary and tampon, otherwise, if the measurements is quite high, if the prolapse thing is if it's larger, then she requires a surgery. That's what she said. And maybe Monday we are going to visit her house, and first thing is we try to convince the father-in-law with the seriousness of her this thing, illness. And if it becomes effective and okay, then I don't know how to convince this guy, because previously I had spoken with him, and he was like a big no to everything. He doesn't want to listen. Something.
Okay, I'm going to stop you there for a second because we're running out of time, but also I'd like to hear what Dr. Aju has to say. One last thing we need to remember, the father is also grieving. He's lost his 38-year-old son. Let's not lose sight of that.
Yeah.
That this also could be his stubbornness, might be a part of his grief manifesting. So it's very easy to take the side of the daughter-in-law and treat the father-in-law as the enemy at the moment. But I think our compassion needs to extend to everybody in the family. So he probably needs some work with grief as well. I just want to quickly touch upon the medical aspect in terms of the urgency. I know that you have a plan of action with the doctor coming across, but Dr. Aju, your views?
Yeah, I'm not an expert in this, but I've seen uterus prolapse and I've seen how urgent it is. And it's unless there's significant bleeding, which I don't think in this case there is, and I don't really think. I think 4 months and 10 days, which is probably already 3 months or 4 months now, 3 months and 20 days maybe now. I think it is probably, it's not a good idea for the father-in-law to command such things, but culturally it's a landmine. Who is the daughter-in-law going to live with? I think this step could actually help her gain more trust or whatever. I don't know. I mean, this does not have any easy answer. Divya has a very hard challenging task. But if you just ask me medically, uterine prolapse, it's not an urgent thing. I think it can wait a bit. It depends on the gynecology opinion too. If it's not bleeding, I think it can wait a bit. It's not something that's super urgent. Yeah.
So here again, we use the palliative care principle of the double effect, right? If you use the double effect in medicine, you can also use it in psychosocial care. What do you need to prioritize? Like Dr. Aju is saying, if by forcing his hand, you might be causing additional conflict within the family, then is that something that you're willing to risk? And also maybe, do a face-to-face meeting with her or with the rest of the family, maybe garner more support in the rest of if it gets to a point where it's urgent, you need the support of the rest of the family to urge the father-in-law. Clearly, he is the patriarch and he makes the decisions. But I'm sure, I mean, she's the mother of his 3 grandchildren. And if her life is at risk, I don't know if he won't come around. But I think you also need to work with his grief. And I think, maybe reframe that a little bit and work with him. I think CCF had some, maybe have something to say, because I saw some interesting exchanges going on there. Does anybody have anything to contribute from that side? Or anybody else, sorry. We have a few minutes, so last comments from other participants. Yes, Rebecca.
Can you unmute yourself?
You have to unmute yourself. Rebecca, you have to unmute yourself. Yeah.
Hello. Why is not the natal family of the daughter-in-law coming into the picture here? I think those people would have enough weightage over this discussion. The natal family of the daughter-in-law, the mother and father of the girl.
No, she has no parents. She has an elder brother. He is not in the picture because all these days he never showed up.
So lack of social support is a major issue then.
Yeah, exactly.
So
she has no one to say clearly. Nobody else other than her husband's family now.
Yeah, as I always think that once a woman in India gets married, she does not just get married to a man, she gets married to the entire family. So that's the problem here. So that's what I wanted to tell you. Sorry for the video. It's in the wrong place. Thank you.
Okay.
Yes, that is. See, the thing is, clearly she really has nobody. But let's not forget, Divya. She has you, and she has your team. So I would suggest just keep in touch. A telephone call is useful, but better than that is a face-to-face conversation. And if, as a woman, you have access to her in her house, visit her. And if the doctor feels that the prolapse doesn't need to be dealt with immediately, let's put that goal secondary to just also resolving conflict within the family, so that she has a better relationship with her in-laws. Because if she doesn't have anyone else to go to, let's create a healthier family dynamic for her and the kids. So that would be my input here. I hope that helps.
Yeah, even that is my priority too. So hopefully, fingers crossed for the gynec opinion. Thank you so much.
Thank you.
So thank you, Divya. Thank you, Dr. AJU, for your wonderful session mentioning about what is pain and what kind of way we can treat it, and categorizing pain, and how a doctor can be a good friend of a patient rather than suggesting the high-rated, all available, scanning and all other kind of checkup measures available. So once again, thank you, Divya, for coming up with this is a kind of practical learning experience for all of us. Thank you, Pranakumar sir, for making the session very interactive by asking the first question all the time. Keep that spirit. I request all the participants to be more interactive, then only we can learn together. So thank you so much. We will see you in next Friday. Wish you a wonderful week ahead.